Morning, everybody, and thank you for joining us today for the eGPlearning podcast as we talk about a digital primary care update with myself, Dr. St. Gandhi, and
Dr. Andy Foster over here on the other side of Nottingham. Hello.
Yeah. So it's an interesting time for us here in Nottingham because unfortunately our COVID rates are doing this, which is not so good. So me and Andy were kind of hoping at some point to be able to start doing the podcast together again. That doesn't appear to be happening anytime soon, unfortunately. But through the power of video conferencing and all that kind of stuff, we're still coming to you live. And if you are joining us, make sure you say hi, put a comment and stuff. We're more than happy and keen to hear those and read them out as well. We've got an interesting episode today, haven't we, Andy? Because there's a couple of new developments that happened literally in the past 48 hours or so that we're going to talk about, including the new flu letter that's just gone round to all practices from the Department of Health, as well as some stuff about CQC, that dreaded acronym that's back again. What are you thinking, Andy?
So CQC have just released a new draft strategy that's out for discussion. There's quite a nice paper, so I thought that we could have a look at that. It's fairly short, 12 pages, so we could sort of go through, and there's some really interesting implications potentially for how the regulator operates. So I think that's quite an interesting document. What else have we got, Gandhi, on the list for today?
Well, we just want to remind everyone, thank you for joining us for our amazing digital primary care conference that we had about 10 days ago, was it now? Something like that. Yeah, it went really well. We had a great time, and I know a lot of people said it as well in the feedback that they had an awesome time, including hearing from all of our speakers, our presenters, our sponsors. We had loads of stuff about digital primary care. We had the amazing Dr. Min Albakai talking about digital first primary care, and topped off by Dr. Nikki Kanani, basically telling us about the future of primary care, which was a really honest and opening session. And I think, hearing from obviously all the other speakers, we had loads of content. We had a few massive announcements, so some key stuff from Ardens and from Redmoor Health and various other providers talking basically about what they're doing for the next few months. So I mean, I had a great time. I don't know how you felt, Andy.
I had a really great time. It's really interesting to see how the sector is developing and kind of new partnerships are potentially forming between players within the sectors, and how everyone's sort of preparing and building their offers out. I find it a really interesting sector just to watch as a sector as well. So fascinating.
And if anybody does want to catch all the videos and stuff that we had from that, we have uploaded them so you can watch them if you want to from the recordings. If you joined us for the tickets and stuff, you'll have free access to this. If you haven't, afraid you may have to register and stuff, but the link's there if you want to do it. And as well, we also announced our next conference, which is our NHS MS Teams user conference. So this is focusing on that amazing new tool that we've got, talking about basically how we can use MS Teams a lot more effectively, both in primary care and within the NHS. And really looking forward to this one, because this is going to focus on nuts and bolts, how-tos, all that kind of stuff, real case studies in terms of how people have been using MS Teams effectively. Again, we've got some support from some amazing organizations like NHSe and Redmoor Health, hopefully looking at basically how we can use this innovative tool for primary care, I think, a lot more effective. I know it's something that me and you have both been trying to use a bit more over the past few weeks and months as well, isn't it?
Yeah, definitely. I think it's a tool with a lot of promise. It's the first time that the NHS has had a kind of true digital collaboration platform that cuts across all the different siloed parts of the NHS. Everybody's got access to it. And there are some great tools within MS Teams, brings together the best of WhatsApp, Zoom, OneDrive, Google Drive file sharing all in one place. So loads of potential. I'm actually keen to see how other people are using it and to get some tips so that I can use it better and help sell it to my primary care network, my practice, and the other services. So I think that's a really timely and important conference. So I think if people are available, they should join us for that session.
Yep. So that's going to be the 4th of November. If you aren't able to join us live, don't worry. As usual with all of our stuff, you'll be able to get the recordings afterwards. Just need to register, really. So feel free to do so. Anyway, we're going to crack on. I think you wanted to ask a question, didn't you, Andy?
So I did. So Gandhi, there was a new flu announcement, I think, that came out last night from Nikki Kanani and NHS England about flu delivery in primary care. And I haven't had a chance to read it. You're often a little bit more on the ball or plugged in than I am. So it might be helpful for myself and viewers, if you just give us the lowdown and tell us what's happening.
Sure. So I guess the big question that a lot of people in primary care have had right now, obviously we're kicking off and getting through our flu campaigns. There's a clear priority to try and vaccinate as many of our population as possible within the required kind of criteria and the groups and all that kind of stuff. But one of the big questions has always been, what do we do when we run out of vaccine? Because the reality is general practice ordered all of its vaccines back in January, February, and supplies have been a challenge. So the letter that came out from the Department of Health last night basically just details what's going to happen from the stockpile that effectively the Department of Health have of flu vaccine, and how that's going to be able, how practices and stuff are able to access that in order to vaccinate larger populations than what they've already ordered for. I guess a couple of key things with this. So this is a centrally held stockpile. There's a variety of vaccines within it. So I think it's 4 different types of vaccines. And they are very clear that practices will only be able to apply for this stock once they've completed all the current stock that they've already ordered. So this isn't a case of, an additional supply. The practices have to have got through what they've already got before they can even apply for this additional stuff. And that's a key message that is repeated throughout the document. It talks, go on, Andy.
I was going to ask a question. So I was on a Zoom call the other day yesterday, and I think Thursday. You were on it as well. And there was a practice who had a problem with their cold chain, and they'd lost their flu vaccine. So they were in a real tight predicament. And obviously their patients have a need and a right to this flu vaccine. Is that the sort of circumstance that might be eligible for it, do you think?
So on that particular one, I'm not sure, because the document is about topping up what practices are going to need to vaccinate, obviously a larger cohort than what we were planning for back at the beginning of this year. It does make clear, so in terms of the supply amounts, practices will be able to apply for up to 10% larger than their practice population in terms of vaccinations. So that is a fair amount of vaccines that practices will be able to apply for. In that particular situation, and if practices are needing more vaccines than what they're eligible for, it does say to contact your local regional team to discuss with them about whether or not you can access that supply. So I think in that particular situation, what we're going to have to say to our colleague is, and I'm pretty sure that the locality team are going to be looking into this after the announcement of the letter, can they apply through this mechanism? Because there has unfortunately been this issue in terms of them losing the vaccines that they've already got access to, which is a real shame, but it's sometimes these things unfortunately happen.
Yeah, and I think this sort of existing supply chain, they'd normally ring up and order some more, but there's just such demand that's not there. So hopefully if there is a stockpile out there, practices in that kind of predicament can access it. But as you say, we'll see. They can be guided by the locality team. So great.
Definitely. And I think additionally with that, one of the things that it does make sure is that, practices won't be, the aim is that you shouldn't be returning these vaccines once you've requested them. So to request what effectively you think you will need, and I think that's one of the priorities why you have to kind of get through what you've got. The reimbursement, because I know many practices will be talking about this, you don't have to pay for the vaccines, and you'll be paid as per the normal vaccination schedule for administering them. So that's a pro. I guess the slight frustration is the letter coming now is a little bit annoying. It would have been really useful to have had this at the beginning, probably September, if they knew they had these supplies and that kind of stuff. Because obviously a lot of practices, I know over the past couple of weeks, we've seen this on social media, haven't we, Andy? And within our own practices, have kind of been doing their schedules. And it's then that question now about, workforce and that kind of stuff. So, a lot of practices probably would have said to their nursing teams and that kind of stuff, try not to take leave in, September, October. Because that's when we're doing our flu schedules. They may have then taken that a little bit more in November and time, but actually the main supply from this Department of Health stock size is going to come middle of November. So there's challenges here. And obviously there is talk about a COVID vaccine as well, isn't there? Which, the second round of doing that, and that's a much, much bigger undertaking in terms of administering that compared to the flu vaccine. So interesting stuff.
True, yeah. Yes, hopefully be more organised if there is a COVID-19 vaccine coming down. But I'm sure everyone will get their ducks in order for that. That would be very important. Yeah, so that's the flu letter. What should we talk about next, Gandhi? Do you want to look at the CQC draft strategy document?
Yeah, so as we mentioned earlier, so this is a slightly more digitally focused kind of topic. So CQC have basically said that they are looking at how transformation has happened across the healthcare system, and they're bringing forth their digital strategy. So this was the article that we've had a read of in HTN, and our colleagues over there at HTN News always reporting on amazing digital health stuff and things. But the document's quite detailed, isn't it, Andy? I mean, I know you had a look at it.
So I've been having a look through the actual document. So I suppose first of all, just some headline observations really. So CQC is acknowledging that it's been a very interesting and strange 6 months, and there's been a lot of changes, and a lot of existing changes that were happening within the system and with technology have been accelerated by COVID-19. And they recognise that as a regulator, they should change and adapt and transform to meet the challenges of this new environment. So I think that's very good, very forward looking. They've, I guess, not been doing face-to-face inspections, so that maybe they've had some time on their hands to use wisely and look at their strategy. Let's just skip through to the document itself. So it's actually a fairly accessible document. It's about 12 pages long. There's an introduction, and it's structured across 4 themes that they introduce as their themes for change and the areas in which they change. I don't think these are going to replace the existing CQC themes, but they're the focus of this draft improvement strategy. Document makes references to the new restrictions in providing care that have been put in place due to COVID-19 and may continue going forwards, the new digital channels which people are working at in much greater volume, or working through in much greater volume, new ways of working. Not going into too much detail, but there's a lot more remote working, and people are structuring and organizing their days in different ways. The environments they're working from are different, and there's new types of services. So these are things which perhaps were already beginning before COVID-19, but have certainly become more prevalent. So I think they're referring to sort of video consultation services and so forth. So they would just want to offer a regulation that remains relevant. So a good way to go through this, Gandhi, might be to just sort of move through the document and pick out some of the key themes. So
cool, let's go for it then.
Let's go for it. Let's get into the nuts and bolts of it. So this is sort of summarizes their new strategic thinking on this, and their new areas of thinking: people, smart, improve, and safe. And let's dive in. So people. So what I picked out from this section is that they are talking about a shift away from perhaps looking at individual organizations to a more patient-centered approach. So they talk about looking at the different touch points on a patient's journey as they are cared for by the whole system. They're talking about empowering people with the data and the assessments that they make to help people make the choices in terms of how and where they use care. So there might be a potential change in how widely they publish, or how well publicized their results are. It's fairly good at the moment, but or how accessible they are for people in terms of making decisions. There is talk of shifting again the focus away from the organization. Will still be very much in the spotlight, but to also look at the effectiveness of the systems that exist around and between those organizations. So I think this has implications for primary care networks, for example, who aren't necessarily a regulated body, but they have some role in the system. And certainly, ICSs, ICPs, and CCGs potentially. And another statement they make is they want a renewed focus on inequalities, and they make quite a strong statement saying they want to champion this in everything they do. So I wonder if there might be more pressure on systems to address inequalities in healthcare. It's very difficult for an individual practice or service to address inequalities. I mean, there are things they can do around accessibility, but to genuinely address the causes of the inequalities, I think, is very different. So, I mean, one thing I'm hopeful for is that there might be pressure on the overall system to respond to this for the regulator and refocus resources potentially in order to address inequalities, because I think that's the only way that really gets solved in the end. But again, have you got any observations around the people area of this? Any thoughts?
I think, like you said, the one that speaks out to me the most is the inequalities element of this, in terms of, there's a massive focus within the NHS and healthcare as a whole to focus on health inequalities. COVID has shone an absolute light in terms of the challenges that health inequalities can pose to a population. And I think, seeing the impact that has as we move forward, and particularly with digital use, the challenges that can prevail in terms of non-English speaking, those with digital poverty, digital literacy, as well as digital health literacy. Those are key things that need to be looked at if we're going to provide a healthcare system that's fit for the next 30 odd years and stuff. So in a way, as much as I get frustrated with CQC, it's nice to see that they are aligning the needs of this along with the rest of the system, because networks have been told that they have to look at health inequalities, ICSs have been told that they have to look at health inequalities. So that alignment principle, I think that will support hopefully a better outcome for the population and things. So making that a key point, I think, is really actually quite sensible and good. How we do it, yeah, that's a completely other part of the question, which I think you're right, putting, this is not something that an individual practice can solve. This is something that has to be approached from multiple different areas and in different ways, because it's partly the repeated message that needs to get out, and the support to help people tackle those challenges needs to be, fully publicized and evident and coming from all the different areas. So yeah, definitely that's my key take home from that particular part.
Yeah, so broadly, I think that the focus is positive, and it certainly implies sort of placing more responsibility on the system rather than individual practices or services, which I'm sure have felt quite threatened and burdened in some ways by CQC in many ways in the past, although they do a good job, and it's appropriate, obviously, that there is effective regulation of the sector. Yeah, another thing just on the systems topic, they talk later in the document, and we will get to it, about developing improvement partnerships with organisations. And I think that feels quite positive, and that's one of the levers I suppose they might be able to push upon to improve the performance of systems. So yeah, very, very interesting. I guess the system and how the system talks to its different components and how they communicate is so important to the effectiveness of care, actually. And I really appreciate the acknowledgement that care is not just what happens in one organisation. The interface between them and the journey through is really, really important. So I think that is quite forward-looking. I think it's a good kind of evolution in the thinking of CQC. Let's move to the next domain, which is smart. And in some ways, I think this is where technology is most relevant. And I reading the document, I think they're looking at kind of two aspects of this. So one is, yes, there's going to be more technology and digital involved in the services that they regulate, but also that they as an organization need to make more use of technological tools to assist them in the process of regulating the industry and the organizations. So I thought that was interesting. So I think what we might see, so focusing on their use of technology, they talk a lot about shifting away from what is currently quite a sort of cyclical, periodic inspections as an event model that they've been using since the beginning of their inception. They do, we have our yearly call, don't we, to monitor our where they talk to us about the data about the practice within the system, but it doesn't feel any more live than that. But they're talking about moving to a much more live data driven monitoring of services, and they talk about being more responsive to that. So rather than perhaps expecting an inspection every few years, the feeling will be that they're monitoring their data streams, which might include quantitative and qualitative patient feedback and all of the other data that's out there. And we do generate a lot of data in general practice, all that other data that's out there, perhaps populating dashboards about our performance that actually if something changes, and they will set their thresholds, obviously, and they talk about using AI and complex data analytics to know when the data might be telling there's a problem. But they basically, I think we're going to see a more targeted inspection regime, responsive to changes. They talk about, it's not good enough that a practice was considered good 2 years ago. That doesn't necessarily tell you very much about what's happening at that practice, that organization now. And they acknowledge that the tools are there for them to be more responsive, and that they should be. So, and I don't think you can argue with that, really, provided the data is good. Well, you're erming, and I was about to go on to say, well, yes, but provided the data is correct, that it is accurate, that it is up to date, because we're given a lot of data that isn't, provided that they are interpreting it in the right way. I mean, there's all sorts of provisos, and they have to get it right. Go on, Gandhi, what do you think about that aspect?
I think it's the way that they extract that data. If this is going to be a system whereby it requires the practice to upload data to another system for them to keep an eye on and that kind of stuff, then to be honest, that's just creating additional workload and additional challenges for, the organizations. This should be something that they could, similar to the way that NHS Digital extracts our appointment data automatically. I would be very keen to see that type of mechanism that can extract the information, in the background, or automatically and stuff. So it doesn't require the practice to have to do significant effort in terms of doing this, because if this is going to be a constant thing, our practice managers are already overburdened, significantly so. Let's be quite clear on this point. The practice managers who unfortunately have to lead the charge with a lot of this, because it is administrative, it is bureaucratic, often the kind of assessments process and stuff. They're overloaded as it is, well beyond, and having to deal with, for example, if the requirement for this came as a monthly upload of XYZ all the way down to XXX and ZZZ and all that kind of thing, then it's just going to be another hammer to knock us on the head with, isn't it? At a time where we really just don't need more.
I guess I don't get a feeling that that's what they're aiming for.
I'm going off the skepticism that we've had with NHS bureaucracy, as it always unfortunately seems to work. I what I was expecting, and what I expected is that they'll be drawing from data that is already known about our practice in the system, and making better use of that. Our outcomes, admissions, QOF data. All of this stuff, and more of that is being extracted live from our systems, as the weeks and months and years go by. So I'm hopeful that there won't be an increased administrative burden. Agreed. That's how it should be.
Gandhi, how do you feel about being sort of silently watched by an AI, making judgments about how you're performing? How do you feel about that?
It's an interesting perspective, isn't it? And the simple analogy I can give to people is the whole concept of being recorded in consultations. That this is a debate that often comes up with clinicians, about patients being able to record you and how would you act differently. In the ideal world, people should always be thinking, no, I wouldn't. And I would hope that's the case. That how you act, whether you record it or not, is no different. But it's an interesting prospect. I think it's one that will definitely make people feel more hard done by. And I agree to an extent, but I think if that information is used to truly be supportive and help practices develop and find the challenges that they're having, and then additionally actually move to a place where they can support us to having tips and ideas of how things could be improved, rather than just you must do this, as unfortunately is often the case with regulators, then it's that element of how responsive they're going to be with it. So
yeah, I mean, so it makes me feel, the instinct is to feel uncomfortable, but actually if this allows them to spot problems quicker and move in earlier, when things have not got too bad, and therefore allows them to take a more supportive position, then actually that might be better for the organizations and for patients, and to allow their partner organizations, if they're forming these improvement partnerships, to target their resources on kind of failing areas of the system or struggling areas of the system better. And maybe that's positive. So this sort of live monitoring, I'm not sure it's all bad. The other thing that I immediately thought of was we've talked about AI systems before, and one of the problems is they're very dependent on the data that goes in, and it's they can become bias in certain ways, and we've seen this in kind of most sort of political or important is you see sort of racial biases, occur within AI systems. And I just wonder, a big problem in healthcare is this effective inequality and this inverse healthcare law where those who need help the most often receive the least attention and funding. And I just wonder if there may be unknown biases within the data. And actually, I think there's obviously there is a known correlation between CQC actions and practices in deprived areas and inequalities. And I just want them to be careful in their use of AI, that they don't compound some of these effects and associations and potential biases that are already there. So, in terms of just inspecting more practices in areas of deprivation rather than not, because of some bias in their system. So that's something CQC, look out for that. But otherwise, crack on. So the other interesting aspect from this element was they were talking about the services that they regulate, and where services are innovative, they talk about looking at how they benefit the people and support the sustainability of the local community and services. And I thought that was interesting. And it just got me wondering if this was perhaps an acknowledgement that some digital services that have been rolled out in the past have been seen to destabilize sort of local health economies and health systems. And the old friends at Babylon Health, who we always say, actually, I've got a lot of respect for, love disruptors, but there was a lot of noise that their GP at hand service was destabilizing to the area of London and the CCGs in local areas there. So I just wonder if there's a nod that they may be involved in making those sorts of assessments. I don't know. What do you think about that?
I think it's an important part to take, and clearly what will come out of it, well, it depends on how stringent and how pedantic and how investigative they're going to be. But yeah, I agree. When I read that, I kind of thought the same thing. Is this being targeted at some of the lessons that have been learnt about, disruption? And I agree with you, Andy, that disruption is often a positive thing in the long run, but it also has, unfortunately, unintended consequences. And then how do you balance that over the need for change? So,
or is it overreach, regulatory overreach? Should they be coming down on disruption like that?
Well, I think one of the criticisms that have been levelled at both the government, CQC, and other areas, that particularly for digital health, there hasn't been much regulation. Actually, there's lots of things that have happened, lots of tech tools and that kind of stuff that have come out, and because the guidance and the structure to actually even try and regulate them is actually quite outdated. Trying to keep up with the rate of innovation has been a real challenge. So, the question of, does a particular innovation come under the regulations of a medical health device, which then puts it under MRHA guidance rather than something else? And actually, what is the other kind of regulation? Because many people don't actually know what they may or may not be, and a lot of people don't really fully understand digital health regulation. Even with our tech heads, to be honest, we're by no means experts on it, but because it's quite complicated. So understanding the implications, the safety, all that kind of stuff comes into play. I think that massively leads on to the next topic, doesn't it, in terms of safety?
Yeah, so safe is the next area, which I think you would expect, and I'm sure it sort of has to be there really if CQC are putting out a document, because that I think that's really their main remit. There's not much surprises really in the safety area, but a few things that I picked out was there's sort of increased references to culture. I know they do. I mean, when we've had them in before in the practice, they used to pay quite a lot of attention to culture anyway, but that features quite highly in the new document. There's an interesting reference to being proactive in supporting and protecting patients, including their human rights. And I don't know whether that's been present actually in previous documents, but I just thought that it was interesting, and I'd be interested to know a bit more about what they mean by that. One imagines it might be in relation to access to services, but from an equality and diversity angle. But I just thought that was interesting. But essentially, they're talking about a shift to being more proactive, essentially, which I think ties up with some of the more focus on live data and live patient feedback, and being responsive to that in terms of stepping in to protect people and support services that are struggling. So interesting. Any observations around those points, Gandhi?
The one I'd like to know about the human rights element as well is that just in application to patients' rights in terms of the user, or is that also applicable to the organizational rights? So again, using the example of clinicians being recorded, I know many clinicians out there feel that a patient being able to subvertively record the consultation is actually an affront to the clinician's human rights in terms of consent and elements of that. Now, I know the MDOs have a different opinion, that it's the patient's consultation, therefore they have the right to record it even without notifying the clinician. But it's that complexity, and which one trumps which. Is it the patient's rights to record out even without informing the clinician? Or what about the clinician's human rights of consent and being able to not be recorded when they don't want to be? Where's that line? So that part of the human rights section that they're going to be looking at, I think it'd be nice to have a bit more detail on, because I think there is a question out there that needs to be answered in terms of what is appropriate and safe. Now, I know often I advocate for many practices to have a social media policy for patients, as well as, obviously each practice should have their own social media policy and stuff. And part of that includes how you approach recording of the consultation, that any clinician should agree to the consultation being recorded, particularly for an element of patient being able to use their notes and refer back to it. And there's real positives for it, but subversively doing it, that massively impacts the relationship with the clinician, and it really speaks of mistrust as well. So there's an element, I think, that really needs to be discussed in that part. And will this open up the discussion? Possibly,
yeah, because you're absolutely right. Staff have human rights as well as patients, essentially. So a specific focus on needing to respect those for your CQC status and inspection. That might raise some interesting conversations. That's a very interesting conversation, isn't it? That might be one for to continue another day, actually. And so, just moving on to the final section, which is around improvement, which I think is nice to see, actually, and that CQC, they always do have a role of improvement, and having knowledge of where practices have had difficulty. It's as provided things are not absolutely dire, it's nice to see that they are given some guidance about what they need to do to improve, and that CQC do already work with other organizations in the local health economy to try and make sure that those improvements happen. But it's nice to see that this is one of 4 areas to focus on, because that's the name of the game, really, isn't it? CQC is there to improve standards in health. So I think it's absolutely right that it's one of the 4 areas that they're focusing on. So what do they talk about in this section? So they talk about making benchmarking information more available to organizations so that they can compare their performance with other organizations, and I think that's other similar organizations, which sounds like a good move to me, actually. And I often find myself sort of asking certain questions, like, I wonder how many appointments per 1,000 patients the surgery down the road does compared to us, because that's quite useful and interesting information when you're considering your own demand management, for example. And there might be all sorts of other bits of benchmarking that might be really useful for organizations to know, so that they can And also sometimes, you can have blind spots, can't you? Organizations sometimes might not know that they're underperforming in a certain area because all they know is their own performance. So making more of this information available, I think, is a really good idea. Obviously, whenever we're talking about data, it has to be accurate, it has to be up to date, it has to be the right data, in order to draw the right conclusions. But on the whole, I think that's quite a positive thing. What do you think about that, Gandhi?
Yeah, I agree. I think the data has to be correct, and I think the concepts of improvement, having data and dashboards and that kind of stuff is useful as long as the information is accurate. I mean, we've done a lot of this previously, haven't we, Andy, in our PCN roles about comparing practices and how they've worked on different clinical areas. So, pre-COVID, we had loads of stuff about looking at respiratory care, looking at diabetic care, and the comparisons for geographical areas, because the theory is that generally geographical areas should have similar challenges, not the same ones, don't get me wrong, but similar challenges, and being able to understand why there might be differences. And I know with that process, one of the key things we often found is sometimes the data is not accurate. So we had two clinical systems, and one clinical system didn't seem to import the same data as the other one. Therefore, there was often parts that were missed. But then also, why? What about those individual organizations makes them so different as well with a similar population? And is there something that they're doing that's better or worse? Is there some external factor that's been affecting them, like bus routes, sometimes can have a huge impact on terms of how patients access care and that kind of stuff. So it's just understanding those complexities. And I think having that data is always a positive thing. Having the headspace and the time to go through that data, a bit more challenging.
But you're right, actually.
Do we need to go through that in a different way?
Yeah, I was going to say, you're absolutely right, actually. My personal experience of working with practices on data in primary care networks is that actually you've got to be really, really careful with the conclusions you draw, because sometimes there is a true difference that is, true variation in practice, and that's the sort of thing that we should be equalizing. But you're right, absolutely. Quite often it's that the coding's not right, and that is something to improve. But the implication of the data being different is that the coding's not right, not that the care's necessarily different. Or there can be all sorts of other factors. I think you've got to be careful. So yeah, I think they have to be very careful. It's a good idea, but they have to be careful in terms of the information they present. I mean, particularly if they're presenting it to patients, which they talk about earlier in the document. I think that they need to be careful to present that within the right context and with the right supporting information, and make sure that the data is right, accurate, and appropriate. So the other thing they talk about in this section, which struck me, was they talked about forming improvement partnerships with local organisations, and often which span the system. And I thought that sounded like a very positive and promising thing to do. And I'm not quite sure of the detail yet, I suppose, of what form that might take. I know that they already work in partnership with our local organisations. They do have contact with LMCs and NHS England and area teams and the CCG to help them kind of target their activity appropriately, and to work post and between inspections for improvement. But I think any increased focus on improvement can only be a positive thing. You got any thoughts about that, or what format that could or should take?
Not sure on that one, Andy. That's a bit more complicated for me.
Yeah, it is, isn't it? I was thinking about this, and I think with partnership with local organisations, I suppose there's an opportunity to be more proactive about improvement. And I also wondered if this might come together nicely with their focus on systems improvement, and that they might be alluding to sort of a partnership with systems to improve their individual components. But it's difficult. It's potentially a bit nebulous, and we're grasping at straws. But it sounds like a nice idea.
Yeah, I mean, it's important to remember that CQC don't just obviously regulate general practice; they regulate the entire healthcare system. So there's hospitals, there's obviously community partnerships, dentists, that kind of stuff. So having the data to compare against the various different parts of the system, like you say, would be quite useful. And then feeding that into things like ICS strategies and that kind of stuff would have potential value. as long as we alluded to earlier, the data is correct. That's the key thing. So, yeah.
So that's the last section of the document. People may be really to know, but I found that really interesting to go through, and it's it is quite an accessible and interesting document. So I'm sure we'll be linking to it in the show notes, and I'd encourage people, if they're at all interested, to take a look. CQC is a big thing that we tend to be afraid of and think of and talk about quite a lot. So it's probably helpful to know in what direction they're intending to go.
Yeah, and I think it's important to remember that it does complement some other stuff that's happening nationally as well. So I know NHS Digital and NHS England are particularly looking at things like online consultations and how they are currently functioning. There's ongoing work looking at how patients can engage with that, particularly general practice, focusing a lot more on things like total triage and digital access. And then absolutely, there's the Redmoor Health digital journey plan, which I think I see as potentially, an additional cog to some of this work, and if not even leading in it, in terms of comparing where practices are on a digital journey and giving them the additional information to help them understand how they can change and improve and tackle some of the challenges they may have with that digital journey to get them further along it. And, different places are going to be different parts. Some practices may be well ahead, further down the line, and other practices will probably be just at the start, particularly in the post-COVID kind of landscape that we have. So, that kind of tool in combination and complementing this one, I think that's a real potential winner, to be honest.
So, Gandhi, the Redmoor Health digital journey planner. So, I didn't make that presentation at the event. It's recorded for all those that went or want access to it afterwards. So that's a great thing for people to link into and watch. But I didn't see it. Now, what I'm thinking is we're beginning to have some conversations about digital demand management tools and access as a primary care network, just beginning. And I was just wondering, is that the sort of tool that might be helpful for a primary care network to do together with its practices, or is there a kind of network application for that? There may not be.
So the journey plan is still in its development phase. They're looking at how and the various different aspects that you can consider in terms of helping patients understand their digital journey with healthcare, and particularly the practices to understand their digital journey as well, because it is a system change element that you have to remember. And it benchmarks various different things, asks questions about what you've done so far, what kind of systems you've already got in place, what capabilities you've got, all that kind of stuff. And like I said, the thing I really like about it, two different things. One, it's a web application, so it's not a spreadsheet, which is a simple thing, but just really nice. And secondly, it gives you tips and tools, and as that information is collated, so they have just started it, but I think as that information is collated, then they can give you more clear data as to how you can change things to potentially improve. I know one of the plans of the phase 3 elements of this, which is the part I'm most excited about, is that then with that information that they glean from practices, they can then help you understand what kind of changes and the subsequent impact that may have for your practice. So, for example, if you were to invest, 20% more time in online consultations, how would that impact the subsequent amount of workload that you have as a result of that? Where would you see the gains in terms of other areas of your practice? So then you can have a much better tool to help you plan the business side of general practice to make it more effective, both for the practice and absolutely more effective for patient care.
Okay, sounds beneficial to me.
Absolutely, and I know that they're keen to have people engage with it. So if you do want to check it out, have a look at Redmoor Health and Digital Journey Planner. All the details are actually in our conference stuff, but if people are interested, just look at the Redmoor Health website. I know they're keen to find people to get on board with it and look at how it works. And I genuinely think it's going to be some really cool stuff. And I think for, complementing, like we said, the work that CQC are doing, the work that NHS Digital are doing, I think it's just going to help practices figure out this whole, digital journey that we're all currently trying to stick our way through, to be honest.
You've just reminded me of something. Or just give me an idea. We really should introduce the locality team to Google Sheets or some sort of, Microsoft alternative, because it drives the practice managers crazy, doesn't it, when they have to fill in all of these spreadsheets to return data to them. And then it must drive the locality team crazy when they have to cut and paste and collate all of these separate spreadsheets. They just need to use a better tool. So we must remind them of that when we get a chance.
Where MS Teams will come into massive, benefit, because the benefit of that one is that it's secure data for patient care and all that kind of stuff. And like you said, everybody across the NHS system will have access to it. So, using smart documents is just such a simple way of doing things. But even then, why use a spreadsheet? You can use web-based databases and that kind of stuff. Look at the criticism that our Pillar 2 testing for COVID has come in. The fact that they kept it all on an Excel spreadsheet rather than a database. And for those that, Excel is an amazing tool. Don't get me wrong. Many businesses run off Excel and the suite that it offers. But there's a massive difference between having information that's manually inputted into a spreadsheet versus information that's in an electronically maintained database. The considerable differences of what you can do with that data is so significant.
Or the maximum number of lines that can exist on the document. And if you exceed that number, then that additional data is not recorded. That was the problem there, wasn't it? They just, the amount of data was too big to fit on an Excel spreadsheet. So the additional thousands of cases just dropped off the bottom and were not recorded or reported. Crazy, isn't it? Okay, well, hopefully they're using databases now. Yes. So, Gandhi, have you got anything else to tell us about today?
Well, just a quick little message to all of our eGP learners. So many of you probably remember a few weeks back, myself and Dr. Ed Pulley did a remote consulting challenge to try and help clinicians in terms of how they've been doing, the challenge of remote consulting, shall we say. And it went really well. We had loads of people join us. We went live a couple of times a day for about a week or so, offering, tips and tools of how you can develop it. And as a result of that, we've come up with something that's probably a little bit more contained and a little bit more depth in terms of how it can support you doing your consulting from a remote perspective. So we've actually got a remote consulting webinar that we're going live with on the 22nd of October. So if you're interested in joining us for that, feel free to do so. It is, something that we're asking people to pay for because it's taken us quite a lot of time to develop the kind of information and learning aspects of it. But if you do so, if you check out the links below, I've put the link in because unfortunately I can't seem to get it to work on here. For an early bird discount, so you'll get in for a lot cheaper and stuff. And this is something that we think is going to be really useful to many people, and we hope that it will give people the confidence of dealing with a lot of the aspects of remote consulting, from dealing with challenging consultations to how to streamline the work that you're doing, to having better meetings, to just simply getting home on time a little bit earlier and potentially even earlier if you can. So yeah, looking forward to it and expanding on the work that we've done for the challenge. If people want to sign up to the challenge, you're still able to do so. It's completely asynchronous. You can just jump on, and it's like an online learning course. So you can join and watch the videos and stuff on that for free. So again, I'll put the links for that shortly down below.
Fantastic. That sounds like sounds an excellent opportunity. So I would encourage people to go for it. So good. Cool. So that probably brings us to a close for our sort of Saturday morning surgery, looking into the world of digital primary care. Thanks for joining us. Any closing words, Gandhi?
Well, just as always, if you are watching us, feel free to subscribe. Definitely leave us a comment down below. We've had a few from some of our viewers today, and hi to everybody that's been watching us. So Mary, Chris, hi to you guys. And definitely, as always, eGPlearning is here to help save you and your patients time by taking hands in your primary care and learning. And we'll catch you in the next episode.
Thanks, guys. Bye-bye.